of the gestation period. So today we are going to talk about more to the abnormalities, more towards the disorders, right? So once you have pregnancy established, it doesn't necessarily mean that you will end up with the new offspring by the end of the gestation period. So there are various types of problems that you may encounter during the gestation period or during the pregnancy period, actually right from the beginning, at the time of fertilization while the zygote is being formed. So from that stage onwards until the end of the pregnancy, there is a possibility of having problems or reproductive disorders, which we are referring here as pregnancy-associated disorders. So we will see some of these important reproductive disorders or pregnancy-related disorders. This includes prenatal loss, the loss of the embryo or the fetus during the gestation period. Number two, we'll also see the fetal mummification. And then we'll see also what fetal maceration is about. And also we'll see the dropsy of fetus and fetal membranes, as well as the fetal sacs. And we'll see also the prolapse, particularly the vaginal prolapse, and some selected metabolic-related diseases, especially the pregnancy toxemia. So these are not the ultimate list of pregnancy-related disorders that you may encounter, but these are some of the selected topics to be covered during this coming two lecture sessions. All right, so let's start with the first one, which is the prenatal loss, prenatal embryo or fetal loss. So as I mentioned earlier, so once you have got the fertilization, when the two gamete cells, they unite together, forming the zygote, so that is the beginning of the pregnancy, right? The conception will be established. So this zygote is expected to develop, and going through the various stages of embryonic developmental stages into the fetal period, and then ultimately to become mature and be able to survive individually out of the maternal body, right? So that survival from the very beginning until the end of the pregnancy period depends on the ability of that embryo to survive during the gestation period, right? Unfortunately, you'll come to know that majority of losses during the embryonic period is causing a lot of economic loss to the to the cattle breeding industry, to the cow-calf operations. For example, in one of the studies reported from the US, annually they have these 40 million beef cattle or beef cows and heifers being exported for breeding. And out of this breeding program, every year they have reported the annual loss because of the embryonic mortality is about 1.2 billion US dollar. So you can imagine the cost, the economic loss that comes together with the prenatal loss, particularly due to the embryonic loss. Okay, so if you remember, we had classified the stages of the intrauterine development into an embryonic stage and then followed by the fetal stage of development. So basically, the embryonic period, particularly in the case of cattle, if you remember, is up to 42 days of the gestation period, right? Then after that, the fetal period will take over until the end of the pregnancy. And that 42 days of the embryonic period also can be sub-classified as early embryonic period and also late embryonic period. So the early embryonic period, covers from the beginning, from the formation of the zygote until the signal of this maternal recognition for pregnancy is established. So this is around 15 to 17 days of the pregnancy period in the case of cattle. So that is what we refer to the early embryonic period. And after that, until day 42, until the organogenesis is completed, we consider that period as late embryonic period. So the embryonic loss, which is encountered during the early embryonic period, is referred to be early embryonic death, ELD, or early embryonic loss. And the one that occurs during the late embryonic period is referred to be late embryonic death. So if you compare these two, the majority of this embryonic loss is encountered during the first 2 weeks of period, right, until the maternal recognition for pregnancy takes place. To some extent, the loss continues to decline, and during the fetal period, meaning after the organogenesis completed, the loss, or this prenatal loss, is very minimal. Meaning it decreases significantly compared to what happened during the embryonic period. So to make it more clear and understand what is happening during this period, I think this is a figure that will show you clearly how this intrauterine life is being affected, and the various stages of development and the period. So right from the beginning, after fertilization and the zygote formation, so you have got the first 16 days, right, until the maternal signal molecule, which is interferon tau in the case of cows, is secreted, which is a kind of call to the corpus luteum to be sustained in order to help the maintenance of pregnancy. So during this period, you will encounter a significant number of embryonic loss. Then after this period, you have got the late embryonic period until day 42, and there will be still a loss expected during this period, but compared to this early embryonic period, the loss is less. And then it continues with the fetal period, and during that period, again, the embryonic loss, or the intrauterine loss, will be much more lesser than the early embryonic period. So this is a report back in 2004, and this shows you the attrition rate, the number of embryonic losses or the prenatal losses at the various stages of the gestation period. All right. So you can see from day 2, that is following fertilization and formation of the zygote, there will be a drop in conception rate to 76%. All right. Which means that we are expecting around 24% of losses at this stage, And then as you go on with the next stage of the embryonic life, by day 6, you will have a drop to 50% of conception rate. So meaning that we're expecting around 50% of embryonic loss. By day 28, which is surpassing the early embryonic period, so we're going to have around 40% of conception rate, meaning that an overall loss of up to 60% of prenatal loss at this stage. Then as you go on, you can see there is a relatively a decline in the rate of attrition, in the rate of embryonic loss. It goes down to 35%. Sorry. 35% around day 42, which is the end of the embryonic stage. And then 90 days onwards, you can see 32%, 30%, 28%. So all the way from day 42 until the end of the pregnancy, you can see just about 7% of loss, which is very much minimal compared to what's happening during the early embryonic period, also during the late embryonic period. So overall, we are going to expect about 60% of prenatal loss during the gestation period, right? Sorry. So it's another example from a different study. You can see here giving you the maximum and the minimum percentage of the loss that you will encounter during the embryonic period as well as during the fetal period. So initially, you can see at day 1, day 1 of pregnancy, you can see you can expect about 5% to 10% of this embryonic loss, when the consumption rate is going to be around 95 to 90%. And then as you go on to day 8, this is the time that you will have the early blastula stage, all right, the morula stage. So by this time, you will have around 25% of embryonic loss, to a minimum, to a maximum of 30% embryonic loss. Then as you go on up to 28 days, you will have additional loss up to 5% to 10%. And then during the late stage of the embryonic period, you have another 5 to 10%, okay? So together it's 10 to 20% during the late embryonic period, but 25 to 30% during the early embryonic period. And then from the during the fetal period, that's after 42 days until term, you can see just a range of 5 to 12% of prenatal loss, which is quite small compared to what happened before this period. So it tells you that the early embryonic period, generally the embryonic period is a more sensitive period whereby you can encounter a lot of the prenatal losses compared to the fetal stage, meaning that once the pregnancy reaches a fetal stage, then it's relatively more stable and much more, a higher chance of survival during the pregnancy period. So talking about this prenatal loss in cattle particularly, as I mentioned, the majority of the losses are encountered during the early embryonic period within the 16 days of the gestation period, all right? And if you talk about the cause, there are many different types of cause that can be related to this problem. One of the cause is performing AI during pregnancy. So this is out of mistake. Then you can be able to cause trauma and introduce infection leading to loss of the embryo. Obviously, some specific infectious agents can also lead to this loss. When the environment within the uterus also not conducive, it can also lead to the embryonic loss, particularly during the early stage of the postpartum period, before the uterine evolution is completed, before the uterus has regained back to its normal non-pregnant uterine environment. If you allow the cow to go for breeding, then the chance of losing the embryo is very high. And of course, nutrition is another important factor. So any deficiency of nutrition, not only the protein, carbohydrate, but also the trace minerals and vitamins are also very important, and we need to make sure these nutritional requirements are to the level of what's needed to the animals. Another factor is stress factor that comes from the environment. Basically, here in a Malaysian environment, one of the important things is the humidity and the heat. So this actually causes a lot of stress factor to the growing embryo, and it can lead to the loss of the embryo. Apart from that, metabolic stress due to high milk yield in those dairy cattle is also another possible factor, because this normally leads to a negative energy balance. And when the cow is facing this negative energy balance, then obviously you will have a problem of this prenatal loss. In other species, like in horses, one of the most important cause of this early embryonic mortality or prenatal loss is having twin conception. So when you have a pregnancy of 2 fetus at a time, this is not something, a good story. I mean, in horses, it can be a good story in the case of small ruminants, for example, to have multiple fetus at a time in a pregnancy. But this is a disastrous kind of a situation for the horses or the mares. So that's why normally early stage pregnancy should be detected. And we need to make sure that that pregnancy is a single one. So we don't recommend to have a twin pregnancy in the horses, because ultimately it will end up with the loss of the embryos. So it can only support like one fetus. So we need to make sure one should be, terminated while the other one is allowed to continue when you have encountered this twin pregnancy. Similar to what I have mentioned, uterine environment also will have an important impact on the survival of the embryo. And one of the things in the bears is it doesn't attach quickly to the uterus. Implantation doesn't occur very quickly. So it stays very long period of time while floating, all the way along the uterine horn. I think that is what makes it also susceptible to face this loss of embryo during the gestation period. So that's another factor for the horses. Perivascular fibrosis, which is the result of post-cervix infection and inflammation. In horses, we do have what we call this post-breeding induced endometritis. So the result of some inflammatory reaction against the semen that is induced or introduced during breeding. So this is a common phenomenon in horses. So as a result of this chronic inflammation, it can lead to perivascular fibrosis, and this can cause prenatal loss. Stress, similar to what we mentioned, some specific infectious agents also are there to cause the early embryonic mortality. In sheep and goat, nutrition is very important, just as we have mentioned before. There are some toxic plants that can also lead to this problem. And stress factors, it could be physiological. The kind of stress that you expect could be overcrowding, for example, in the case of small ruminants. Similar effect of heat stress, as we mentioned for cattle previously, and also some specific infectious agents also can be a cause of embryonic loss in small ruminants. Okay, now what will happen, when the embryo or the fetus dies inside the uterus, right? So we need to know after the loss of the embryo or the fetus within the uterus, what will happen next, right? Because that's going to be part of the management procedure when you have got this kind of problems that you need to be taking into account. So prenatal loss, we can classify based on the stage of the intrauterine development. So we have an embryonic stage. We have also loss that can also be encountered during the fetal stage, right? So when the loss happens during the embryonic period, so we can have this early embryonic mortality or late embryonic mortality. So in the case of early embryonic mortality, because the embryo is still very, immature, and it's yet to have, the organogenesis to be completed, the bones to be developed, and so forth. So the chance or the ultimate result of this early embryonic mortality is complete resorption. So the fetus, the embryo will be completely resorbed back into the system, and the cow might come back to a normal estrous cycle without, having any irregularity in the cycle. So you might think even this cow was not pregnant from the first round of breeding. But on the other hand, when the embryonic loss is encountered during the late embryonic stage, so this late embryonic mortality can be followed by infection and followed by development of pyometra, which refers to the accumulation of pus in the uterus. So there will be some degree of absorption here, but there is also possibility of having this sequelae of having a pyometra established. When you talk about fetal stage, when the loss is encountered after day 42 in cattle, for example, there are sequelae that we expect. One of the things is abortion, all right, the expulsion of the dead fetus out of the uterus. And on the other hand, there are some other sequelae that we'll be discussing later on, including fetal mummification, fetal maceration, all right? So these are some of the consequences or the sequelae that will follow when the prenatal loss is encountered during the fetal stage. Let's look each of these sequelae one by one. One of the things is pyometra. As I mentioned, this is condition whereby it can be encountered after having late embryonic death, during the late embryonic period, all right? So embryo might be resolved, but because of possibility of having infection to follow, then you can have such a case of pyometra. And this is characterized by the having a persistent corpus luteum in the ovary, all right? And then accumulation of pus. This is, you can see a distended uterine horn and body due to accumulation of pus. And you can see by ultrasound also a uniform echogenicity of hyperechoic, pus content within the uterus. And the cervix is usually closed, meaning that is a closed kind of pyometra that you can have. But at some point, you may have also the cervix being open and the discharge coming out from the vagina. Another sequelae when the loss is encountered during the fetal period is a fetal mummification, all right? So this mummification of fetus usually occurs when the fetal loss is encountered after the development of the skeleton, all right, after the bone ossification has taken place. Usually this is after 3 months of pregnancy until the end of pregnancy. So you can have during that period of gestation. So this condition is characterized by having a fetal fluid resorption, meaning that, when the fetus dies, there will be a soft tissue component of the fetus, the fluid part of the fetus. So the fluid part can be resorbed into the system of the maternal circulation. So ultimately leading to a shriveled fetal membranes with a dry, and a contracted kind of uterus over the fetus. And that is resulting in a formation of a papyraceous kind of mummification. So it becomes a mummy, right? Very dry, contracted against the wall of the uterus with the fetal membranes shriveled over the area of the fetus. And the fluid part is resorbed, meaning it becomes dry. So this is commonly encountered in polytocous animals, and in those kind of animals, you can have still a viable fetus continuing to grow and end up with the patrician, while one of them can also face fetal mummification. So you can have, fetal mummified fetus besides another viable fetus in the same uterus up to the end of the pregnancy. And this is true in a polytocous animal. And it's also very common in pigs associated with this porcine parvovirus infection, which is known to cause a condition known as SMADI, which means stillbirth, mummification, embryonic death, and infertility. And it can be also encountered in dogs. Sorry. It's characteristics to canine herpes virus if it is encountered in dogs. And in a small ruminants as well, it can be encountered, especially with those animals having multiple fetus. But this case is reported to be rare in mares. So this is an example of the mummy that you can see. And to talk about a bit of detail in cattle, the report for the incidence of this case in cattle is about 0.13 to 1.8%, which is relatively low, right? And the kind of mummification that you encounter in these animals is hematic kind of mummification, all right? And the name hematic is given because of the chocolate-colored, secretion that surrounds the fetus that you find around this shriveled and dried fetus. And this is believed to come from hemorrhage of the caruncles, which is part of the fetal chorion, right? Part of the fetal, the placenta, right? So, as I mentioned, this condition is encountered after the formation of the bone. So we expect this to happen during the second and last trimester of pregnancy. So in this condition, you expect the pregnancy to be prolonged, all right? And usually this condition is suspected when you have a history of, the cows being delayed for gestation. So you might have an expected day for pasteurization, but the farmer might not see, this cow giving birth. So then they might be wondering, why it has been already overdue and not yet, giving birth. So at that point in time, you can start to suspect probably maybe this cow is having this kind of fetal mummification. So the causes are not very clearly understood, but there are some causes that can be linked to this problem. One of the things is umbilical cord torsion. So remember, the umbilicus is the blood supply that comes from the maternal body. That communicates the fetal circulation and the maternal circulation. So if a torsion happens to the umbilicus, then obviously it will disrupt the supply for nutrition and exchange of gas, as well as for the waste products. And this ultimately leads to the death of the fetus out of hypoxia and lack of nutrition. Hormonal disturbance is another possible factor, and this has been established experimentally using certain hormones, like using estradiol and trenbolone acetate injection, indicating that whenever there is a disturbance in hormones, you can also have this fetal mummification. Another factor is genetics. When you have a genetics error that leads to the death of the fetus, not able to continue to grow, then when that fetus dies, then it's followed by mummification. This table gives you an example of most common causes for each of the different types of species of animals that we have. So for cattle, from the infectious causes, we have BVD. This is bovine viral diarrhea virus infection. We have trichomona also, which is a parasite. In horses, as I mentioned, twinning is one of the most important factor. In swine, again, parvovirus infection, which is known for the Asmedi syndrome, kind of a problem in swine. Canine herpes virus infection for dogs, ectopic pregnancy in swine, torsion in cats, and as well as toxoplasmosis and chlamydophilia in the case of small ruminants. Okay, so talking about treatment. So once you diagnose this problem, then how are you going to manage it? So the treatment options that we have primarily is injection of prostaglandin. That's the first line of treatment that you can consider, with the hope that by regressing the corpus luteum, you can be able to lead to the expulsion of the mummified fetus, right? But you may not be able to succeed with the first injection of the prostaglandin. So then you have to think another option, all right? And during treatment, one of the things that you have to take into account is if your treatment is just partial kind of effect in opening the cervix, but not able to expel completely the mummified fetus out of the uterus, then you are predisposing for another form of pregnancy-related disorder, which is maceration. So infection will take place, and then that can lead to another form, which is a fetal maceration. So we have to be careful on that. So this is a diagrammatic presentation for a treatment decision tree for mummification. It can also apply to maceration. We'll see that later on. So as I said, the first line of treatment is PGF2 alpha, prostaglandin. So after you give this injection, so you expect the expulsion within the next 2 to 4 days of treatment. So the options or the possibilities are either you succeed to expel the fetus, or maybe no response, no expulsion. So if you are able to succeed by the expulsion of the fetus, then that's great. So what you need to do is you lavage the uterus, and then the cow will get back to the breeding cycle with another breeding program, and you expect the consumption rate, which is normal, without being affected. All right, normal consumption rate. On the other side, when there is no expulsion following the first treatment with PGF2 alpha, so another option that you can do is you repeat injection of VEGF2 alpha again. So that's around day 5. So after you give the second injection of VEGF2 alpha, then again you have got two possibilities. One is you might succeed with the treatment. Then you just what you need to do is you lavage the uterus and then let the cow to go for breeding, and you expect a normal conception rate to be established. On the other hand, if you don't succeed with this second injection, meaning if the mummified fetus is not expelled, then you have to think again another options of treatment. One option that you have is to go again medically to give another PGF2 alpha injection along with PGE2. This PGE2 is useful for the dilatation of the cervix, to let the cervix to be open, because one of the challenge during mummified fetus is cervix might not be adequately open. So if the cervix is not completely, open, then very difficult for you to get the mummified fetus to be expelled out. To facilitate this relaxation of the cervix, you might use PGE2, prostaglandin E2. So this can be topical, applied directly on the cervix. So hoping that it will facilitate the expansion of the cervix. So with this treatment, again, you will have two other options, but the other option that you have is to go for the invasive procedure, which is the cesarean section, the surgically to remove the mummified fetus. So, and then after surgical recovery, you expect a drop in conception rate. All right. So far, we have been expecting normal conception rate, right? But after this hysterectomy or after cesarean section, you're going to have expected conception rate of 38% because of the treatment option that we have and the time delay. On the other hand, here, after you use this medical treatment approach, so the option is that the possibility is that you may be able to succeed by expulsion, and by then you just simply lavage the uterus with normal saline, and then you can allow the cow to go for breeding. And with this, you might expect to have a 66% of conception rate, all right, which is much better than the one that you have after the cesarean section. On the other hand, if still after this medical treatment, after this stage, the fetus is not able to expel out the mummified fetus, so the last option that you have is to repeat the same thing. To do the surgical removal of the mummified fetus, but there's no data here how much conception rate you can be able to achieve from this report. So this is a treatment decision tree that you can follow when you have this kind of problem. Now, the other type of this pregnancy-related disorder, which is coming as a sequelae subsequent to the prenatal loss during the fetal stage, is fetal maceration, all right? So this is a condition whereby, when the fetus dies, but it fails to be expelled out of the uterus, right? Meaning that there is abortion, but following the abortion, the fetus is not expelled out, so remains inside the uterus. Not only that, there will be infection in this condition. So whenever there is bacterial infection, the bacteria, what will it does? It will undergo putrefaction and autolysis, right? As you know. So the autolysis process and the putrefaction process, as a result of the bacterial enzymatic action on the soft tissue component of the fetus, what will happen is that the soft tissue component of the fetus will be dissolved, all right? And because of the dissolution of the soft tissue component, what will be left will be the bony part. So the bony part of the fetus will remain disintegrated because of the muscle, everything has been digested, right? So as you palpate through the rectum, you'll feel bony stuff, without having a membrane, no placenta, you don't feel those structures, and the fluid part is minimized, so you will have just the bony parts being felt and disintegrated, not like the mummified fetus, which is like a single entity, compact and shriveled. So, and one of the thing that we have to be careful here is that those bones which are disintegrated as the result of dissolution of the soft tissue, they may embed themselves into the uterine wall. So because they become sharp, they become sharp, so there is a tendency that they may be embedded into the wall of the uterus. And that actually can lead to a very chronic kind of inflammatory process to the uterine wall, meaning that leading to chronic endometritis. And the removal of the fetus will be very difficult in that situation. So in this condition, your ultimate decision would be culling or salvaging the cow for slaughter, right? This is just an example of a case in one of the farms from this ladder anchored grove in Langing, and you can see what we see here is a jawbone that was extracted through the vagina, right? So cervix was open, and as you go inside, you can feel the bony mass of the fetus with the soft tissues being dissolved. So there was a discharge coming out from the cow, which is a browny kind of foul-smelling discharge because of the putrefaction and the autolysis process. So, but it's very difficult for you to be able to remove all the components, and some of them might be embedded on the wall of the uterus. So if you try to remove by hand through the vagina, that's going to be very risky. You might even cause bleeding and rupture of the uterine wall. So that's something you have to be careful. So this prolonged gestation also can happen during this kind of fetal maceration period, as well as with the fetal mummification. But one thing which is important we need to remember is that delayed gestation period or a prolonged gestation period can happen not only due to fetal mummification or due to fetal death, but if there are some developmental defects with the fetus itself, it can also lead to this prolonged gestation or a delayed gestation period. One of the example is when you have a fetus with this developmental defect known as anencephalic pregnancy, which means like lack of a complete development of the brain and part of the skull. So that is what we call anencephalic pregnancy, and which is associated with absence of fetal pituitary gland, all right? And this gland is very important in order to trigger the cascade of parturition in normal physiological condition. All right, we'll talk about parturition in another lecture, and we'll see how parturition, the physiological process behind the parturition process. So for it to happen, we need to have the fetal hypophyseal gonadal axis to be intact and functionally normal. But if not, for example, if you don't have a pituitary gland there working normal, then you can end up with the failure of inducing parturition process, meaning that it leads to a delayed gestation period. So just the fetus will be maintained and will be carried on for unpredictable or unpredicted time period within the uterus. So, and in this case, if fetus is alive and continues to grow, then you are expecting dystocia to happen because of absolute fetal oversize, all right, because of extended gestation period and development of the fetus. Okay, so far we have seen the fetal maceration and the fetal mummification as a sequelae of fetal death during the fetal period of gestation. So what other sequelae do we have when a fetus dies during the fetal period of gestation? So one of the things is abortion. We have another lecture on this topic to see it in detail. This is just expulsion of the dead fetus from the uterus. Another sequelae is stillbirth. This is when you have a fetus dying at the time of birth, all right? And this can occur associated with developmental defects, not enabling the new offspring or the new calf coming out being able to survive individually. So what additional pregnancy disorders we have among the list that we have mentioned is the dropsy of fetal membranes, vaginal prolapse, and the metabolic disease. What is our time? Okay. So we'll try to see some of these topics until the time allows us to go on. So dropsy of fetal membranes. We are talking about, when we say dropsy, we are talking about abnormal accumulation of fluid inside within the body of the fetus, in some of the parts of the body of the fetus, or within the fetal membrane itself. All right. So you may classify based on the location where you have this abnormal accumulation of fluid into three. So we have a placental, fetal sac, and dropsy, which is associated with the fetus. So when we talk about placenta, you know about the placenta. Talking about the fetal sacs, basically we have got two main sacs, if you remember, when we talk about the placenta and the fetal membranes. So we have the amniotic cavity that surrounds immediately the fetus or the embryo, and we have, apart from the amniotic cavity, we have also the allantoic cavity that surrounds the amnion. So this abnormal fluid accumulation can happen in either of these two fetal sacs. And when you talk about the dropsy of fetus, it can happen in the head region, all right? It can also happen in the subcutaneous space or tissues, or it can happen within the peritoneal space. So accordingly, we have three different types of these fetal dropsies that we'll discuss later on. Okay, now let's start with the dropsy of the placenta, which is the edema of the placenta. And this is frequently reported accompanied by placentitis. So when you have inflammation of the placenta due to infection, for example, due to Brucella abortus infection that targets the placenta during infection, it can lead to inflammation of the placenta followed by edema, accumulation of fluid. So this is the way how this edema of the placenta can be encountered. Well, it doesn't cause the dystocia when you have fetal placenta dropsy, but usually it's accompanied by abortion or stillbirth. So pregnancy may not be able to maintain up to the end of the pregnancy. You know that when the placentitis is attacking the placenta, all that exchange of nutrition, gas, and other essential materials between the dam and the calf will be interrupted, and ultimately the fetus will die and get aborted. Or if it is able to survive until full term, then by the time the calf is born, then you will have a stillbirth issue. Second type of dropsy of the fetal sacs. So as I mentioned before, we have two main fetal sacs, the amnion and the allantoic sac. So when the fluid is accumulating within the amniotic sac, we call it hydramnion. And whereas when it is within the allantoic cavity, it's referred to as hydra-allantois. So these are the two conditions that we have with regards to the fetal sacs of the fetus or the fetal membranes. So hydramnion, usually it results from the whenever there's a problem with the fetus itself, particularly when the fetus fails to swallow and absorb amniotic fluid. So remember that the fetus is floating within the amniotic fluid, right? Covered by the amniotic sac. So the fetus will continue, to absorb, to swallow and absorb the whatever amniotic fluid being secreted, and it goes into the circulation and then excreted via the maternal body circulation. But if the fetus is unable to do so, so that amniotic fluid being secreted by the membrane will continue to accumulate, right, within the amniotic sac, and leading to the formation of this hydramnion. So the major cause of this condition is whenever there's a defect in the fetus itself. Whereas the hydra-allantois, which involves the allantoic cavity, is associated with more on the placental dysfunction. So when there is a problem with the placenta, remember that the chorioallantoic membrane is the one that is involved in the formation of the placenta, right? In attachment with the endometrium. So because very close proximity to that, so if there is anything wrong that happens with the placenta, then you expect this hydroallantois can also occur, because there is no that normal exchange mechanism for the allantoic secretion to be regularly monitored and excreted out, right? So when there is a dysfunction of placenta, then the retention of fluid will be there within the allantoic cavity, and this leads to the formation of this condition, which is hydramnion. So mainly this is a condition that is commonly encountered in bovine, all right, even though it has been also reported to occur in other species of animals like in equines. So most cases of these problems usually encountered during the last trimester of the pregnancy, all right, because the development also process takes some time, and is frequently associated with twins. So this is condition of hydroallantois. As I mentioned, the development process can be progressive. So it begins somehow early and then continue, from time to time, accumulating over and over again until it's clinically very significant, and you can be able to see it from physical examination. So primarily, this is, as I said, is a result of dysfunction of placenta. And the nature of the fluid that you will have, it looks like the plasma of the blood, all right? It's a blood plasma kind of content. So clinically, what will happen is, at least from the physical observation, you can see this kind of pear-shaped abdominal distension bilaterally. You can see the distension, which is a pear-shaped kind of abdominal distension. On top of that, depending on the stage of development, all right, whether it's start developing from the beginning of the last trimester, or starts developing like towards the end of the last trimester, meaning like 6 months, or maybe from 8-9 months onwards. So if it begins to develop quite early during the last trimester period, then the chance of getting this condition very severe is very high, because you have a long way to go, right? And the accumulation of fluid over that time period will be huge, leading to a very severe clinical condition of this hydrolantois. But if it starts developing, I mean, quite close to the end of the pregnancy period, probably it might end up without causing much problems to the cow. So generally, the clinical sign will depend on the time when this hydrolantois starts to develop, and if you consider about the amount of fluid accumulation that you can have, it can vary, up to a volume of 273 liter. You can imagine how huge is the amount of fluid that can be accumulated. I mean, with this condition of the hydrolantois. And when you have such a severe form of accumulation of fluid in the allantoic sac, then animal or the cow, the dam will show sign of straining, the respiration will be, depressed, when hampered, appetite of the animal will reduce, and there will be a gradual loss of condition, recumbency, and death also can happen if no intervention is given. So sometimes, out of the process of this effect, then the cow might end up with abortion, and that abortion might give relief to the animal from this, distension, and causing excessive pressure on the abdominal organs and on the respiratory process. So, and then, even if this condition can, be carried on up to the limit of the end of pregnancy, but by the time of pregnancy, you should expect that there will be dystocia, difficulty in birth. So meaning that you have to be ready to assist the calving process during this time. And most likely this is due to the uterine inertia, because the wall of the uterus will be quite distended, and there will be loss of that elasticity and the strength to contract during parturition to get the fetus out. So you have to expect the giving assistance to the cow during the calving process or during parturition. So for diagnosis of this case, basically we depend on the clinical sign. As you have seen it, there will be marked distension of the abdomen, having a P-shaped kind of abdominal distension. So, but depend on the amount of fluid that is accumulated, this clinical sign may not be visible in some conditions. I mean, if it's early, not a chronic condition. But what you can do is clinical, you can examine through the rectum, you can perform rectal examination, and by doing so, you can be able to appreciate a distended wall of the uterus because of the fluid accumulation. You may not be able to palpate the fetus because of the expansion, the distension, and placenta also may not be able to may not be able to be felt because of excessive thinning on the wall of the uterus as well. You might be able to use ultrasound to be able to detect the viability of the fetus, whether the fetus is still alive or not, right? You can use ultrasound to examine its condition, also to see how much fluid you have accumulated within the allantoic sac. Okay. So treatment-wise, if the condition is very severe and you find the animals recumbent, then in this condition, what you need to decide is you have to let the cow to go for salvage, for slaughter, all right? But otherwise, if you think that the situation is not that severe and the condition is not that very severe, then you might consider to do elective cesarean section or induction of parturition. So induction of parturition medically by giving hormones like PGF2 alpha, you might give a trial. If that doesn't help, then elective cesarean section will be an option to remove the fetus. And this is for near-term cases. I mean, the gestation period is almost complete. So during elective cesarean section, there are things that you need to take into account, especially the precaution that needs to be made is when you do the incision over the uterus and let the fluid to come out, you have to be very careful. You need to make sure that the fluid leaves the uterus slowly, in a very slow manner. This is in order to avoid hypovolemic shock. Suddenly, if you have that huge amount of fluid lost from the body, then the animal will succumb to, or the cow or the dam will succumb to hypovolemic shock. So in order to avoid that, you have to allow the fluid to escape slowly from the uterus, okay? And because this condition is encountered usually with the twin pregnancy, so you need to make sure that after you remove one fetus, double check, I mean, for the presence of another fetus so that you don't forget it before you close back the uterus. Possible complication after this treatment is retention of placenta. You will have uterine infection, metritis can also be encountered. And the uterine evolution process is expected to be very much retarded, all right? And also conception can be delayed. So the expected breeding capacity following this problem is reduced. So for parturition induction, if that is the option that you want to do for the treatment, then as I said, you can go for prostaglandin alone or in combination with dexamethasone, all right? Or you can also use dexamethasone combination with oxytocin. So, but this has to come after confirming the cervix is dilated using the dexamethasone treatment. So meaning that you cannot give the combination at the same time. So you give out dexamethasone first and then wait and check for the cervix to be relaxed within 4 to 5 days. And then after that, you give the oxytocin as IV drip. Dropsy of fetus. We have 3 minutes more to go. I think maybe I can just quickly finish this one. So when we talk about dropsy of fetus, as I mentioned, this is when you have abnormal fluid accumulation at the various parts of the fetus, parts of the body of the fetus. So one of the example is when you have accumulation on the skull, within the skull, or on the head, which is known as the hydrocephalus. Another condition is when you have the subcutaneous space being involved, anasarca. And another condition is when the peritoneal space is involved, then you have this ascites. So the hydrocephalus, because of that abnormal fluid accumulation with the cranium within the head, then you will have the swelling of the cranium. There will be swollen cranium, or the skull or the head will be swollen. And usually the space where you will have this fluid accumulating is the ventricular system, the space between the dry matter and the brain. So this can be encountered in all species of animals, but commonly reported in pigs, puppies, and calves. All right. Looking at the science and treatment of this condition, the severe form, there will be a marketing of the cranium because of distension. All right. So during this time, you can be able to apply trocarization and compression for vaginal delivery. So you will have access through the vagina, reaching the head, and you can feel the head of the fetus, which is having this hydrocephalus. So you can trocarize it and allow the fluid to escape from the head and decompress the head of the fetus, and then the size will be minimized and the vaginal delivery will be possible by doing so. The other option is to do phytotomy, meaning that the dome shape of the head, the one I showed you here, okay, it can be sewed off. You can cut off the head part of the cranium. So by doing so, you can minimize the size of the fetus, and then you can allow the normal delivery through the vagina. The last option is you have a C-section. You can perform C-section. If you cannot be able to manage to get delivered by using the two options mentioned above. All right, I think it's not a good idea to rush with this thing. I was expecting to cover these 3 slides and stop here. Anyway, we'll continue with the topic next lecture with the dropsy of the fetus. We'll continue from here. So I think that's enough for today. And if you have got questions, you can email me or you can drop it in Blast so I can respond to your questions. All right. So see you with the next lecture on Friday.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.